So our first topic is cardio-oncology, looking at bridging vascular and cardiac disease in patients with cancer. Our first speaker is Dr. Ninian Lang. Ninian's a clinical senior lecturer here at the Institute of Cardiovascular Medical Sciences at the University of Glasgow. Ninian leads the cardiovascular oncology research team and also leads the clinical service, the cardio-oncology service here in the west of Scotland. It really is a service and a research theme which is very broad and has broad interest to lots of us. So I'm really excited to hear Ninian's talk, Cardiovascular Oncology, Out of the Frying Pan and Into the Fire. Ninian.
So thank you very much, Rachel. Thank you, Rianne. I'll just share my screen. I'm very pleased to be able to bring you some update really on cardio-oncology in general, but also the work that we've been doing here in Glasgow. And I think, as the theme has already been, a lot of this is presenting on behalf of the research fellows who really are at the coalface and putting in the real effort here. So why do we need cardio-oncology? Well, we are playing catch up in the cardiovascular world to the successes of the oncologists. If you were diagnosed with cancer in the 1970s, you'd be half as likely to have a meaningful recovery or to live with well-controlled cancer as you are now. So there are a huge number of, and a growing number of patients who have had cancer or are living with well-controlled cancer who are now at risk from cardiovascular disease, both in the short, medium, and long term. You can see these are data from the United States looking at death from the major cancer registries in groups of millions of patients. In black, we can see is the death from cancer causes, and in red is death from cardiovascular causes. And you can see that for a large number of different cancers, the difference between cardiovascular and cancer mortality has decreased substantially. And in fact, in breast cancer, patients who have survived more than 8 or 9 years, cardiovascular disease has actually become the predominant cause of risk over cancer. Breast cancer has been well highlighted, but actually this is not just confined to that group. There are another growing range of cancers where the survival has been much better, and I would highlight in particular melanoma here, which I'll come on to a bit later. Now, of course, some of this reflects changes in competing risks. If you don't die from cancer, then of course you're more likely to die from something else, and cardiovascular disease being more common. But there's also shared risk factors and exposure to potentially cardiotoxic or cardiovascular toxic drugs. And we've known about potential for cardiovascular toxicity from cancer chemotherapy since the 1970s, really, when anthracyclines made their most major impressions. We knew that patients could present sometimes 5-10 years later with substantial heart failure that's often resistant to standard therapies with a very poor prognosis at that point. But that was accepted almost as a necessary evil to allow anti-cancer therapies to be given when there really wasn't any other major option. But I think as cardiovascular specialists, we've been guilty until more recently of not really paying a huge amount of attention. And I think the real change came when trastuzumab or Herceptin came online for the treatment of women with breast cancer. And it became obvious fairly early on that these drugs were associated with very substantial incidence of heart failure. I'll come on and talk about that. But what that really meant was that cardio-oncology and cardiologists became interested, and there was a lot more thought on these drugs. But it also took us back to thinking about how we might be able to manage patients with anthracycline-related cardiotoxicity or risk of that better. And more recently, this has really expanded and exploded with tyrosine kinase inhibitors against a variety of targets and also in immunotherapy. I'll talk particularly during this talk about anthracyclines, Herceptin, and some of the tyrosine kinase inhibitors. My colleague, Stephen Dobbin, is going to talk a bit in particular about VEGF inhibitors, so I won't steal his thunder at present. But you can see when I was saying that we need to catch up with the oncologists, we were talking about survival in terms of catching up. I think in the cardiovascular world, we think that we have a rapid rate of drug development and introduction. But if you see here, these are data 10 years out of date now, but in the top blue line, this is anti-cancer compounds in development. And this is now increasing at an exponential rate. And often these drugs, certainly historically, have been developed by cancer scientists, oncologists, not necessarily in conjunction with cardiovascular specialists who might have a different take on things and might think that actually some of the potential cardiovascular toxicities may be predictable or even mitigated if we think about these at an early stage and work together, coming at this from not just an anti-cancer point of view, but from the point of view of minimizing the side effects. And I think this probably applies to specialties beyond cardiovascular medicine, of course, as well. So how does cardiotoxicity present? Well, I think there's sometimes a perception that cardio-oncology is a specialty of a subspecialty of a subspecialty, but my argument really is that cardiotoxicity can present in any form. Now, what it's predominantly been born out of is its effect on myocardial function, left ventricular systolic dysfunction, heart failure, but it can affect any part of the heart. There's a substantial instance of vascular disease, metabolic derangements, arrhythmia, electrical conduction disturbance. And so what I would say is that cardio-oncology really is general cardiology, but you are faced with the competing risks of a cancer diagnosis, and you have to be pragmatic in understanding those balances, but also to understand the potential short, medium, and long-term effects of what may be fairly potent toxic effects of some of the anti-cancer drugs. So as Rachel said, I run a cardio-oncology service, and this is based at the Beatson West of Scotland Cancer Centre, which is one of the biggest and busiest cancer centres in Europe, but is a cancer centre and doesn't have access ordinarily to more general medical or cardiology services. So I run a clinic here once a week with links to our large tertiary centre at the Queen Elizabeth University Hospital. And of course, down here on the right, this is the British Heart Foundation building where we run our research endeavours, and linking in a big way with our ICE, or Imaging Centre of Excellence, also the Queen Elizabeth. A lot of what we do focuses on imaging, and in particular cardiac MRI. So in cardio-oncology, we've got a growing number of documents. Some like to call themselves guidelines. Some are position statements purporting to tell us what to do to manage and perform surveillance for patients at risk of cardiovascular toxicity. But as I think I'll persuade you, the evidence base informing these documents is really pretty borderline and basic, and certainly in comparison to general cardiology, where we have been spoilt and we're used to working in a world where we have many randomized controlled trials with strong guidance and evidence to tell us what we should be doing for our patients. A lot of this comes from work that is in progress, and there's a huge unmet need. Historically, cardiotoxicity has been split into two different forms. Type 1 myocardial damage, classically thought to be a reflection of injury from drugs like doxorubicin, the anthracyclines, classically thought to be irreversible, dose-related, with structural changes to the myocardium. And this was said to be in contrast to type 2 myocardial dysfunction, classically again, really born out of trastuzumab or Herceptin, thought to be reversible, idiosyncratic and unrelated to dose, and not associated with the same structural abnormalities as would be seen with anthracyclines. But I think what I'll show you in the next few slides is that really this is an outdated and oversimplified suggestion that actually may be more harmful to progress in thinking about cardiotoxicity. So to talk about Herceptin, I think really this is as I said at the beginning, was the birth of cardio-oncology. And this was because in the initial trials of treatment of women with breast cancer, just under 30% of women would have substantial left ventricular dysfunction or heart failure. But it became apparent fairly early on that if you separated the administration of anthracycline and trastuzumab, you gave a few weeks at least between giving those drugs, that you could reduce the incidence substantially. And then in meta-analyses of the trials, there was still an incidence of about 7.2% of left ventricular dysfunction, just under 2% heart failure. But of course, these were trials, and patients with comorbidity and older patients were often excluded or not recruited. So here are registry data from America, again, just showing this cumulative incidence of cardiovascular toxicity, left ventricular dysfunction and heart failure. After 5.5 years, 20% of patients treated with anthracycline and Herceptin developed heart failure. And importantly, patients exposed only to trastuzumab, about 12%. So this, I would say, is still an unacceptably high number. So what I said earlier was that the conventional or prevailing wisdom was that trastuzumab, Herceptin-related cardiotoxicity was a phenomenon that was reversible and that should reverse after exposure to the drug ceases. Now, these are data from Denmark. These are looking at patients with heart failure, so a hard endpoint, not just asymptomatic left ventricular dysfunction. And if you look at women treated with Herceptin over the first year or so, there's an expected and unsurprising incidence of about 1.6% who develop heart failure. Now, that's all well and good, but what's more interesting is that if you then go on and perform a landmark analysis, so remove these patients from your analysis who have already developed heart failure, and then look in the subsequent 7 or 8 years, you'll see that there's a doubling of what we would call late heart failure after exposure to Herceptin. And this is important because if you think that a Herceptin toxicity is only apparent and only important while receiving the drug, these patients may well be discharged from the clinic, may well have potentially preventive or protective therapies such as ACE inhibitor and beta blockers stopped. But actually, I think there's a signal coming through that some of this might actually be a much more long-term problem. And we need to think a little bit more carefully about the patients who need longer-term therapy and longer-term follow-up. This is work in progress, but an important starting point for thinking. And that's exactly what this has made my colleague, Dr. Manjan, who's a clinical lecturer here in Glasgow, think about. So he's currently recruiting women who have a distant history of breast cancer treated with Herceptin at least 7 years before, and is performing very detailed cardiac MRI to understand not just the incidence of left ventricular dysfunction in terms of ejection fraction, but also more subtle markers of myocardial injury in terms of fibrosis, edema and scar, as well as understanding more fundamentals of cardiovascular risk, including hypertension and metabolic abnormalities. So I think this work will be important in understanding whether or not we are right to be reassured that Herceptin cardiotoxicity is only a transient phenomenon, or whether or not we should actually be thinking a lot more carefully about this group. That's work in progress. So I'll move on from Herceptin. Historically, I suppose back in time to the anthracyclines, but actually in terms of what we think and what we know, some of this is a little bit more recent in terms of data. So these drugs are like doxorubicin, epirubicin, used in a broad range of malignancies, breast cancer, a lot of use in hematological malignancies, otherwise known as the red devil. So patients always remember, or almost always remember, being exposed to this red intravenous drug. And it has a terrible reputation for having a prognosis much worse than most other forms of cardiomyopathy. Now, this is data that's often presented from the New England Journal, but it's out of date. It's 20 years old and looked at patients recruited and followed up in the years prior to that. And I would say that if we were to repeat this, it probably wouldn't be quite as demoralizing as it is here, but there's still a lot of work to be done. The concern, as I said at the beginning, was that anthracycline-related cardiotoxicity was an irreversible phenomenon, and perhaps people were a little bit, gave up a little bit in terms of thinking about this. Now, these are data prospectively collected by a group in Italy, non-randomized, but nonetheless prospectively followed patients receiving high-ish doses of anthracycline, and anyone who developed cardiotoxicity, left ventricular dysfunction, non-randomized, but brought on with ACE inhibitor and beta blocker. And you can see that if you introduce the treatment early on in detecting this drop in left ventricular ejection fraction, then the vast majority will have at least a partial, if not a full recovery in left ventricular function. So there is something we can do for these patients. We need to follow them. We need to see this. And in fact, it does tend to occur. If it occurs at all, it occurs within the first year. So if you follow these patients, get treatment on board, they may well have a good and meaningful long-term recovery in terms of their cardiac status. But what can we do to prevent this from happening in the first place? What can we do to reduce the risk of anthracycline-related left ventricular dysfunction? Well, these are data collated in a meta-analysis of 17 trials. Now, this really just exemplifies the issue we have in cardio-oncology. So in many of our cardiology trials, we recruit several thousand into one trial. 6,000 would not be particularly unusual. It's taken 17 trials to recruit just under 2,000 patients. Most of these in patients with breast cancer, and mainly looking at an outcome of left ventricular ejection fraction, and mainly looking at upfront treatment with an ACE inhibitor, angiotensin receptor antagonist, and or a beta blocker to prevent left ventricular dysfunction. So if you introduce some of those agents, then it does appear that there's a significant effect on left ventricular ejection fraction, a 4% difference in left ventricular ejection fraction in those pre-treated with one of those agents, at least one of those agents versus without. But there's huge heterogeneity in those trials, and almost none of them are powered to look at hard cardiovascular events, heart failure, hospitalizations and death, for example, and there's no longer term follow-up. So we really don't have enough evidence to suggest that everyone that is receiving a potentially cardiotoxic anthracycline dose should receive upfront ACE inhibitor and beta blocker, for example. So can we do better? Well, what we do, we try to follow these patients up, and we use a lot of imaging, a lot of echo, sometimes like to use 3D echo, sometimes like to use more advanced echo techniques, including global longitudinal strain. But this is time sensitive. There's inter-observer variability. Sometimes can be difficult to get views. So there are other things that we can do. Well, maybe troponin is a good marker of myocardial injury. And you can see here, these are patients followed up after starting anthracycline therapy. And patients who have a supposedly low troponin throughout have a very good cardiac event-free rate. Patients who have a transient elevation in troponin, which does not persist into the longer term, have a less good outcome, and those with persistent troponin elevation do particularly badly. Now, that's all well and good, but if you see that in this group, the cutoff for troponin elevation was 80 nanograms per liter, and that was in that contemporary assay in 2004 and prior to that. But if you think that in a woman, in the right context, we would diagnose myocardial infarction, the troponin of greater than 14, you can see that this is probably quite a blunt tool for examining cardiac injury and risk. But nonetheless, it's a start. So what we've been more interested in is looking at smaller changes in troponin to predict cardiac risk and potentially to guide the introduction of therapy. So this this graph represents follow-up between Glasgow and Edinburgh of people treated with anthracyclines, and rather unsurprisingly, with increasing dose of anthracycline, there's evidence of an increasing release of cardiac troponin, which is taken to represent anthracycline-related cardiac injury. Now, that dose response is interesting. Now, don't worry too much about the detail here, but the point I want to make is that actually what we're also able to do is that by looking at the change in troponin between cycle 1 and cycle 2, so these are still small changes, but that small change at the beginning, we can then predict which patients will be the ones who go on in later cycles and in later time points to have a more significant and substantial elevation in troponin. So we can predict the change in troponin here from a small change at baseline to cycle 2. And does that therefore mean that by targeting that group with a small change early on with potentially cardioprotective medicines, does that mean that we can then prevent longer term effects on left ventricular function? So we're currently looking at that in a randomized trial sponsored and co-funded by the British Heart Foundation and NIHR, cardiac care. Patients receiving anthracyclines are recruited and undergo baseline cardiac MRI and otherwise have normal standard oncology-based treatment. At each anthracycline treatment cycle, the troponin is measured. If the troponin rises above 6 nanograms per liter, so that's a small rise in troponin, but still we think may be relevant at that time at cycle 2, or if it rises above 23 nanograms per liter at any other subsequent time point, patients are subsequently randomized either to standard care, which essentially is watch and wait and see, versus candesartan, the ARB, and carvedilol, the beta blocker. And those drugs are titrated to the maximum tolerated dose. At the end of chemotherapy, or 6 months post chemotherapy, they will undergo a further cardiac MRI. So the idea here is to understand whether we can enrich our population to understand those who may benefit from exposure to ACE inhibitor, ARB and beta blocker to prevent cardiotoxicity, but also to understand whether or not troponin blood tests may in fact be an alternative, or at least may allow the rationalizing of the use of labor-intensive cardiac imaging. So we're just about completed in recruitment of that, and we hope to report in the next 12 months. So we've discussed Herceptin, we've discussed anthracycline. I'll briefly mention BRAF and MEK inhibitors because this is an area that's captured our attention recently. So these drugs are used in the treatment primarily of melanoma. About 60% of patients with melanoma may be eligible for treatment with these drugs. They're also used in colorectal cancers sometimes, and also have growing indications elsewhere. These drugs include dabrafenib and trametinib. And importantly, like many of the anti-cancer agents, they act on pathways that are also very important in the cardiomyocyte. Now, these have been poorly characterized in trials, but it does seem that at least 20 to 30% of patients develop hypertension, and perhaps at least 15% develop left ventricular systolic dysfunction. But this is very, very poorly characterized. So we don't know the best way to surveil for this. We don't understand the mechanisms particularly well, and we don't understand the time course, reversibility, etc., etc. Important things for our patients, particularly because these patients are often now being treated in the adjuvant setting, which means that these are patients with otherwise good prognosis from their melanoma. So we do not want to swap one set of problems from the cancer for another set of problems in terms of cardiovascular disease, or even worse, have the combination of two, an untreated melanoma and left ventricular dysfunction and possibly heart failure. So what Claire Glenn here, new research fellow, is now doing with support from Roche Diagnostics is recruiting patients treated with these drugs prospectively. 100 patients will have very detailed cardiovascular phenotyping before and during treatment over 24 weeks with these BRAF and MEK inhibitors. She'll be examining effects on atheroma from CT, standard CT. Half will be having detailed cardiac MRI. There'll be detailed assessment of blood pressure, ECG, endothelial function, and peripheral markers of what we would describe as rarefaction, loss of blood vessels, using capillaroscopy. And also making good use of urinary and humoral biomarkers, again, to understand whether there are early markers for cardiovascular toxicity. And by understanding these, we can perhaps move on to be more personalized in thinking about what preventive and therapeutic strategies may be most helpful for these patients at risk. and also understand those patients at greatest risk. So in summary, everything in cardio-oncology is, of course, a balance between cardiovascular outcomes and cancer outcomes. And we can't do any of this on our own without the oncologists and the cancer scientists. But I think cardio-oncology is increasingly relevant. I've shown you that cancer survivorship has increased dramatically. Cancer treatments have expanded rapidly, and they are being applied to an aging population with an increasing burden of comorbidity. There are lots of documents or guidelines growing in number, but they really do have a borderline evidence base. And so on that basis, there's a real urgent need to better understand the incidence, mechanisms, the timing of onset, and whether or not some of these toxicities are reversible, and who are the patients at greatest risk for cardiovascular toxicities. And only by doing so can we get the best surveillance, prevention, and treatment strategies and allow patients to really derive what can be very, very striking anti-cancer effects without coming at an unacceptable cardiovascular cost. So with that, I'll finish, but I just really wanted to highlight that this work is really led by the fellows, some of whom you'll hear a little bit more from today, but they are the ones who are leading this, and I'm very grateful to them in particular. So with that, I'll finish and hand back. Thanks.